Okay, everybody take your seats. We've we have to keep on time or you won't get your lunch. George Tebow, where are you? There you are. Come up and say a few words, would you? George is the president of the Macy Foundation and part of the founding of this.
Right. So I'm George Tebow. I'm president of the Josiah Macy Jr. Foundation, the only national foundation devoted to improving the health of the public by improving the education of health professionals. And we're excited to be here as part of this. A major theme of our work for the last 9 years has been interprofessional education as a way to not only transform education, but importantly transform the healthcare system. And this is a perfect example of that. So we're proud to be a part of this effort with Judy Haber, proud that one of our Macy faculty scholars is a part of it, but particularly proud that this is such an important area. So think about portals. In many ways, the dentist's office is the portal to the healthcare system, and the oral cavity is the portal to the body. And only if we integrate oral health and dental care with the rest of the healthcare system will we take full advantage of that. And only that will happen if we train people interprofessionally and we practice interprofessionally in a collaborative way. And that is the theme of this meeting and why we are so proud to be a part of it. And I will anticipate our next speaker by saying I'm also proud to be on the same podium with my dear friend of long standing from our Harvard days together, Bruce Donoff, who is truly a pioneer in dental education. So thank you all for your participation. Thank you for making us proud to be supporters of such an important effort. And I'll let you get on with it.
It's a pleasure to introduce Bruce Donoff. I think almost everybody here knows his name and probably knows him. It's truly remarkable that, because I had to look this up, he's been dean of the Harvard Dental School for 25 years. I think that's an amazing run, and it just reminds me of a small comment that I heard several years ago. I mentioned to somebody that when I was at the Mass General, there were these two oral surgeons, Bruce Donoff and Charles Bertolami, and now both of them are deans. Charles was at UCSF and Bruce at Harvard. And I said, what do you think about that? And my colleague said, you're the lucky one. Bruce.
Well, thank you very much. I'm not sure I deserve that introduction, but one of the reasons that I'm able to do this is on Monday I will operate at Mass General Hospital because I haven't given up taking care of patients. And to your issue of the importance of saliva, I remember Ron Malt and his experiments when he caged rats together and they licked their wounds. The wounds healed better. And that got him very interested in saliva. So on Monday, when I scrub for the OR, I will gown up, put my gloves on, and go, let's go. Easy to do. I think there are two themes of this meeting. One is the importance of experiments and pilots, and the other is often crises lead to change. So listening to Hal talk about the National Institutes of Dental Research, I'll remind everyone here in the room that it was the third institute at the NIH in 1948. And the reason it was the third institute was 20% of recruits for World War II could not pass the physical because they didn't have 7 upper teeth and 7 lower teeth, so they could pull the pin on a hand grenade. And that's what got oral health and dentistry into the NIH quickly. From a historical point of view, the term 4F came from the Civil War, because if you didn't have your 4 front teeth, you couldn't fix the flint on the rifle that you needed to fire in the Civil War. And then pilots. What we're doing here is going to lead to experiments and pilots. Listening to Mike, who had a great idea of merging nursing and dentistry years ago, and the kinds of fights that he had, reminds me of the kind of fights that existed before. There was a Dean Ory at Columbia who got booted out because of his crazy idea that medicine and dentistry should be together. But Mike is the product of a very extensive, important experiment at MIT, an MIT PhD in oral biology that produced Mike and a number of other dental leaders in oral health over the years. So these things are very important. I'd just like to take a few minutes, if I can have my slides somewhere, to tell one other story, because I'm a storyteller. What kind of doctor are you anyway? When I started as a house officer many years ago at the MGH, one of the first patients I saw for facial pain had a quite prominent butterfly rash. And I said, aha, having had the kind of education I had, this lady may have systemic lupus. And I checked her out, referred her medically. The next time I saw her a few years later, was at an arthritis grand rounds at the hospital. A gentleman, Professor Kurt Block, asked me to see her. I was on the staff at the time, because she had a parotid enlargement. She had been diagnosed with Sjogren's syndrome, and in those days, they used to submit those patients to 600 R of radiation, okay? There's only one problem with that radiation. It led to lymphoma, and she had a lymphoma of the parotid gland, which I wound up taking out. Later on, during my surgical training, I saw her on the OBGYN service for another kind of problem, not the oral orifice. In any case, we took care of that. And then several years later, I saw her in the oral surgery clinic. She needed a tooth out, and I took the tooth out. And she looked at me and she said, "Dr. Donoff, what kind of doctor are you anyway?" That's what we're talking about. So, if I have, I can control it here? Great. There are lots of examples to consider here about groups working together. The London cholera epidemic was solved by a priest and a physician. The idea of conciliant thinking is an important one. It's when thinking from subject areas far different from each other come together, and it leads to a better overall goal. That's what interprofessional education is about. The formation of the first dental schools was by physicians. The formation of the Harvard School of Public Health, I just learned, in 1916, which was a collaboration with MIT, was with a physician, an engineer, and a microbiologist. That's pretty interprofessional. This is an important study by Julio Frank and Lincoln Chen, Health Profession Education for a New Century. The important thing was it stressed that what had become silos, nursing, public health, the Flexner Report for medicine and the Guy's Report for dentistry, needed to come together. And if you look at the bottom, I'm sorry I don't have a pointer. Oh, maybe I do. No, I don't have a pointer. If you look at the bottom, it says health professional education should be outward-looking. Education should be linked with delivery systems. It should be the norm. It should be competency-based. That's what we're talking about, and it's not necessarily Flexnerian. That report in 2010 maybe got read by a few more people than read the IOM report, Dental Education at the Crossroads. But there are a lot of efforts to bring the mouth back to the body. We're going to hear from a panel that's doing some very important work, and these are all pilots and experiments. NYU, DentaQuest, HRSA and their Advisory Committee on Training in Primary Care Medicine and Dentistry. Ken Wright from Kaiser is going to tell us about some exciting things going on there later. The Center for Oral Health in Barzega's group. We have a Harvard initiative that looks at economic imperatives, educational efforts. I'll share a paper that I did with Sarah Gordon on the kinds of problems and issues that face dental schools in terms of getting together on IPE. And last but not least, scientific evidence efforts that now are based on the economic parameters. This is a paper that hasn't appeared in the dental clinics of North America yet, Problems and Solutions for Interprofessional Education in North American Dental Schools. Because there are problems, it's not so easy. I mean, at Harvard, we have a tremendous legacy of being in a single faculty of medicine, and that's been very important. But not all dental schools have that kind of thing. The conversation needs to switch from how is oral health connected to systemic health to how is oral health integral to overall health. Consider sleep apnea. Sleep apnea is the new hot area in oral health. Why? Because dentists get reimbursed for the mouth appliances that they make. So they're learning about sleep apnea. This is not an insignificant model for us to learn from. We need to change the culture. The dental approach, I'm sorry to say, is making accreditation standard. So critical thinking is an accreditation standard. Doesn't mean critical thinking is taking place. Research is an accreditation standard. Does it mean more dental schools are doing research? I'm not sure. There's a shift from financing procedures to financing outcomes. There's a pressure on providers to become more efficient. And there clearly is more integration of healthcare delivery and healthcare financing, and this will happen more and more. What makes this relevant? We heard some of this. The new science that Hal spoke about. An aging population. He mentioned Japan. In Japan, they're looking at life expectancy. They're looking at life expectancy in terms of the number of teeth that the elderly have left. And there seems to be a correlation, believe it or not. And not the least important fact that there's a primary care shortage. So we've had a few things that we've tried. It won't all get spoken about here, but this is Initiative for Integration. Jim Bramson heads that, and he may say a little bit about it. We've had curricular change in the medical school and dental school, and we now have a primary care practice in the dental center on Wednesday mornings with physicians and dental students and medical students and faculty working together. We have what we call an oral physician general practice residency at the Cambridge Health Alliance, very integrated with medicine and family medicine. Maria Dolce in the audience has this HRSA program with Northeastern U that's part of us now, where we have nurse practitioners coming into the dental school on Wednesdays, seeing patients with the dental students together, managing their chronic diseases. They learn about oral health. And we just received a 5-year HRSA grant in collaboration with the Harvard Center for Primary Care, UMass Family Medicine, Northeastern, a whole bunch of people, to look at creating an academic unit for the integration of oral health and primary care. And last but not least, we've talked, and we will hear a few more examples of combined practices, developing a practice of the future with the Center for Primary Care. And this is close to happening. Here's the vision of this nurse practitioner clinic that goes on. When the medical school presents their new curriculum and talks about having primary care sites, you can see listed here, you see the Brigham and Women's, you see the Mass General Hospital, you see the Cambridge, you see the Beth Israel, and right in the middle, you see the dental school. So being included in this kind of thing makes it far easier to be part of this kind of movement, and we're really blessed with that kind of situation. But new pathways exist. We'll hear about what nurse practitioners, physician assistants, last but not least, dentists need to be part of this. They need to change the scope of their practice, and I wouldn't rule out combined degrees and new kinds of programs, because when oral health is not in your repertoire of activities, it's out of mind, out of mind. And I've seen too many examples of this not to think that we might need another double degree program. Richard Mansky at University of Maryland has had a very interesting paper on increasing the scope for dental practice. His idea is that you need to get together a medical school and a dental school, speak to state legislatures, have them change their regs even on a limited basis, and start treating medical and dental students the same in terms of oral health and other kinds of educational activities. And I recommend this article to you, which was in the Journal of Public Health in 2015. Clay Christensen, he of Disruptive Innovation, has made another statement. He says that you used to have to go to the Home Depot to find something to work on your house, or to Best Buy to get technology, but now you can go to one place, Walmart, to get them both. Used to go to a gas station to fill your car up with gas. Used to go to a 7-Eleven to get a snack. Now you go to a gas station with a snack place in it and fill it at once. So what's the job that people are trying to get done? And maybe the time has come for a combined office where there will be dentists and physicians working together with others as well. So this is right from the city. I grew up looking across the river in Brooklyn, and my mother would be very happy that I'm at NYU, because she always wanted me to come to NYU, and I deserted her. In any case, this is at Rockefeller Center, and it says, "Wisdom and knowledge shall be the stability of the times." And I think that's pretty much true, except if you look across the way, there's a huge Lego store, okay? And there it says, "Creativity and imagination shall be the stability of the times." And that's what we're going to hear about today from all our panelists. And so, no further ado, I will simply ask the first panelist, who is Anita Glicken, to come up.
Thank you.
And tell us what, physician assistants are doing. I didn't think you changed your area.
Hello, everybody. I appreciate the clear podium so I can see the front row and they can see me. You know, in February of 2007, when newspapers, is this okay if I do this? Newspapers across the country carried the story of the death of Diamante Driver. If you were a physician assistant, a nurse practitioner, or a doctor, you might have read that story and said, "What a shame. Too bad we couldn't do anything about this." Well, it's 9 years later, and those same providers are learning that by redefining the problem and viewing it through the lens of an integrated healthcare delivery system, they're very much an important part of the oral health solution. As a founding partner of the NIAOH, the National Interprofessional Initiative on Oral Health, physician assistants are part of a growing movement to integrate oral health into primary care. And I'd like to spend the next 10 minutes sharing with you a little bit about how the PA profession addresses this issue. So oral health integration often starts, as you've heard, with one program. And at the University of Colorado in the early 2000s, our schools of medicine and dentistry seized an opportunity to increase oral health screening and preventive services by creating an interprofessional curriculum in oral health. Our curriculum brought students together from the School of Medicine and the School of Dentistry for an IPE learning experience. Our dental residents provide instruction in oral health in prevention, diagnosis, screening, varnish, and our PA students then practice in pairs on each other with the supervision and guidance of their dental colleagues. Here's what we found. There was a general increase in oral health knowledge, including knowledge about the oral systemic connection. Both professions learned an increased understanding of what PAs can do in terms of the provision of oral health care. And in 2006, we added IPE oral health simulation using standardized patients and using mannequins for all health profession students across our campus. Now, we know that the problem is never getting never getting new ideas into our head, but getting the old ones out. And as one of the early adapters of oral health, we realized that we needed to scale up our efforts. And to do that, we needed innovative strategies, and we needed effective tools that would help support the new practice standards. This graphic actually shows the opportunity, the progression of the field, and the growth of oral health policy documents that are driving change across our healthcare system. We recognize, however, that change happens not only due to the research and policy that dramatically impacts our thinking in the field, but also the result of the investments that we make in people that can make change happen. Those practical visionaries on the ground that can support our work and help us create and scale up a movement that can move change forward. So, like the NIOH, we strategically sought to develop champions, to cultivate leadership, to facilitate interprofessional learning and agreement, and to provide tools that create a common knowledge base, understanding, and communication related to skills and knowledge about oral health. Our primary tool is Smiles for Life. Smiles makes the right thing to do the easy thing to do for our providers. Because Smiles is intentionally profession neutral, it allows our students, faculty, and providers from multiple health professions to build a shared understanding of oral health. Over the past 2 years, we've seen an exponential increase in the use of Smiles for Life, now endorsed by 17 health professional organizations and 7 health professions. Over 83,000 courses have been completed, and close to 500,000 visitors have come to the site. And PAs have completed the most modules of any health profession. One of the reasons for this may be that our PA initiative is grounded in a strategy of what we call collective impact of our national 4 PA organizations. Our ARCPA organization accredits all 210 PA programs. The Physician Assistant Education Association is the umbrella organization for all ed programs in the country. The NCCPA certifies every PA in the country for practice, and the AAPA is our Academy of PAs. These organizations have committed to doing what they're uniquely capable of in mutually supportive ways to advance oral health across the PA profession. And over the last 6 years, organizational leaders have come together to plan, to commit, and to learn. Notably, it's the first time these professional organizations have ever worked together. One thing collective impact allows us to do is to maintain continuous communication, not just across our organizations, but across all of our stakeholders. And each organization sends out regular communications to all PAs in the country. These are just a sample of some of the peer-reviewed articles that have been published. We started with 2 in 2009, and now there are over 50 original articles in PA literature and other literature about oral health. As you'll see in the future when I talk about the next couple of slides, research and evaluation isn't just designed to measure our progress. It informs our new strategies and helps us learn that it's not what we learn, but what we do with it that matters. This slide and the next show just a few examples of how our organizational activities and the resources we've created are supporting PA interprofessional collaboration around the integration of oral health competencies. Each national organization is doing its part to push system-wide change in PA practice. For example, oral health is now integrated into our national certifying exam. And our PA Student Academy has adopted a Washington Dental Service Foundation project called Project in a Box that advances interprofessional community service activities in 22 states across the country. Our Health Foundation has created an award-winning video series, again profession neutral, called Joining the Fight for Oral Health, that encourages others to work with us on issues like health equity. Our PA program accrediting body uses oral health as a way to promote standards in IPE and in public health. And our Education Association has created student interprofessional oral health scholars programs that bring students together from across disciplines to learn about leadership and advocacy in oral health. resulting last year in 10 academic institutions integrating and launching new IPE oral health programs across their schools. PA membership organization, they've created new CME, continuing medical education, in oral health in diabetes and cardiovascular disease. In the first 6 months of this year, over 2,000 PAs signed up for these CME modules. Our strategies reach beyond education into practice, and we've engaged a new group of leaders, those running health centers. Melinda Thomas at Boston Healthcare for the Homeless is helping lead change across 250 medical, nursing, and behavioral health providers at 70 states. Training up our medical staff has also allowed their co-located medical and dental clinics to really share and become closer and more integrated so that now their patients and their oral health records can move across the system seamlessly. Our champions are also leading change in specialty care. Disty Pearson, in her research project, explored the impact of an educational oral health intervention with patients with congenital heart disease, a project that's now being replicated at other academic institutions in the U.S. and abroad. One of our most notable projects consists of a 2-day faculty development oral health workshop at our Education Association's annual meeting. These workshops combine didactic sessions with active learning through community service activities, where faculty provide oral health screening, education, and fluoride varnish application. These undiscovered oral health champions really come together to learn about oral health, about leadership, about advocacy, and they leave as leaders prepared to go back to their institutions and lead change in their institution and in the communities. How do we know this? Well, in 2014, we published a study that we did on follow-up of these faculty, and we found that unlike traditional CME, which has limited success in changing behavior, our faculty went back and 80% of them had integrated elements of the curriculum or completely integrated it into their programs. We also know that IPE is messy, and therefore we also try to support this integration. For faculty who integrate curriculum and evaluate outcomes, we provide faculty grants. This slide captures a unique adaptation of an ADA Give Kids a Smile event, resulting from one of our faculty awards. This was a unique IPE service event that not only met the needs of uninsured local families, but allowed students to learn from, with, and about each other and their unique roles in advancing oral health. So what have we learned about our national impact on the PA education front? Well, a study published last year of all PA program directors revealed equally promising results. 78% of the respondents indicated that they were including oral health in their curriculum, and that was a significant increase over a 2008 baseline study. And this, we have, 78 variables that we looked at. There's a lot of integration and having a lot across schools and programs. There's now 45 new PA programs currently under development. So we're really working together to identify new strategies to sustain and grow that PA oral health initiative. But we know that measuring integration into education really is important, but it really doesn't tell us whether we're impacting patient care. So this year, for the first time, a unique partnership funded by a cooperative agreement from HRSA is allowing our professional academy to work with the Center for Health Workforce Studies to track 2014 PA program graduates to look at their capacity to integrate oral health into the practice setting when they arrive. What have we learned? Well, we've learned that organizational change process really requires system-wide intervention, and that having the right people in the right place for the right reasons can change ideas in practice. And a key really is having the right tools and strategies to impact those knowledge, skills, and attitudes of our providers, and collaboration is key. We can't do this alone. And with the support of our funders, we're working together through oral health to build leaders and a system, an integrated healthcare delivery system that's fair, just, and equitable. We really hope that you'll join the PA profession and work with us towards this end, and I really appreciate your taking the time to listen to this window into what's happening in oral health and how we're readying oral health providers. Thank you.
Thank you, Anita. Our next speaker from our home institution is Erin Hartnett, who is Director of Oral Health Nursing Education and Practice and teaching oral systemic health programs at the NYU Rory Myers College of Nursing.
Okay.
I'll go this way.
All right, thank you. Thank you. Thank you all for coming. Welcome you here. And I'd like to just share with you a little bit about what our ONAP program has been doing. First, I'd like to thank our funders, the National Interprofessional Initiative on Oral Health, the Washington Dental Service Foundation, and the DentaQuest Foundation. So the aims of our ONAP program are first to advance a national oral health agenda in the nursing profession. And second, we want to increase the workforce capacity in primary care. And then to integrate oral systemic health in both the undergraduate and the graduate nursing curriculum. Doing this with faculty development, curriculum integration, and the development of best practices in primary care. But why nurses? Well, first of all, we are the largest health profession. There are over 3 million registered nurses, 200,000 nurse practitioners, half of them in primary care. We have 13,000 midwives, and we are voted the most trusted health professional. In addition, we're everywhere. We're in schools and camps and hospitals, outpatient, inpatient, private offices, home care facilities, long-term care. Everywhere you can find a nurse, and we're used to communicating and collaborating with all different health professionals. So our oral health workforce model is based on the World Health Organization interprofessional model, and we believe that by educating our students in interprofessional oral systemic health and collaborative practice, we can increase the primary care workforce in oral health and thereby decrease oral health disparities, increase access, and improve outcomes. So as Anita mentioned, we also use the Smiles for Life interprofessional oral health curriculum as the basis for our curriculum. It's got a lot of different professions using it. As you can see, the physicians, nursing, physician assistants, and the light green bars, the students. So it's got wide use interprofessionally. It has 8 different 45-minute modules that cover the whole lifespan with the important oral health core concepts in it. It also has developed a app that is used on your mobile device, and you can use it right in the clinic. So at NYU, we have put the mouth back in the head, and we have taken the traditional HEENT exam, head, eyes, ears, nose, and throat, where we were all taught you go right from the nose to the back of the throat and totally skip the mouth. So we've changed that to the HENOT exam so that our students have to do head, eyes, ears, nose, oral cavity, and throat, and they cannot skip the oral cavity. They have to include it in their history, their risk assessment, their physical exam. They also have to include it in their plan, their collaboration, and their referral. And this article is published in the Journal of Public Health. Okay. We've also developed an interprofessional oral health faculty toolkit. It's based on the HRSA competencies, the IPEC competencies, and the NOMF competencies, and the 6 different nurse practitioner nurse practitioner programs, as well as the midwifery program. It's a turnkey product that any faculty member can go to, and depending on what topic they're teaching in their course, they can find articles, case studies, photos, quizzes, so that they can integrate oral health into whatever they're teaching. But as we know, faculty is not going to teach something they don't know. So we hold faculty development workshops. We've had one each year for the past 3 years on oral health, interprofessional competencies, team steps competencies. We've also brought our preceptors in and given them an oral health workshop as well with live standardized patients. Now we're concentrating our efforts on clinical experiences for our students, interprofessional clinical experiences. The dental students we have 5 dental students every semester, and they take health assessment with the nurse practitioner students, and the following semester they work in the nurse faculty practice with a nurse practitioner student and a nurse practitioner. We have collaborative case conferences with dental hygiene, and nurse practitioner students. Our service learning, the adult nurse practitioner students and the dental students go out to the senior centers and do oral cancer screening. The pediatric nurse practitioner students and dental students go to the Head Starts and do oral exam and fluoride varnish. And then the pediatric nurse practitioners teach the dental students behavior management of the children. We've developed for our simulation lab both a pediatric and an adult oral health mannequin, which the students can use to recognize oral pathologies. And we've just collaborated on a virtual avatar clinic with the University of Vermont. And our students can go in and work together virtually with all different kinds of students with a patient who has an oral systemic problem. For our clinical rotations, our nurse practitioners also rotate through the dental clinics, and then our dental hygiene and dental students rotate into the nurse faculty practice. And 2 of our biggest projects are where we combine nursing, dental, and medical students together. And this is our interprofessional oral systemic simulation project. This is the 4th year we've had this. We have 300 students each year from the 3 different schools, and they have a standardized patient, and they work together as a team. The dental student teaches the oral exam, the medical student the cardiac exam, and the nurse practitioner student the pulmonary exam. And after working together, then they go in and discuss it and as a team and make a plan for this patient. So for this project, we have them do an interprofessional collaborative competency attainment survey before and after. And we have almost 1,200 of these surveys now over 4 years. And this is based on the IPEC competencies. And our data from the past 3 years shows that all the students, there's a significant change in their attitudes and knowledge about the interprofessional competencies from the pre-survey in green to the post-survey in orange, just after this one simple experience. And it also shows that our students also are very similar. All 3 student types, very, very similar. So we feel that this gives us evidence that this is a very effective way to teach interprofessional oral health. Okay. We also put all 3 types of students together in a pediatric oral health clerkship, and the students work in the Bellevue Dental Clinic and the Bellevue Medical Clinic as an oral health team facilitated by the pediatric dental resident. And they take turns doing different parts of the patient care, always working as a team. And with this, we're also collecting the same data. We just don't have quite enough yet. But we can't just concentrate on our students because there are so many nurses out there who haven't had oral health. So we had a workshop at the Pediatric Nurse Practitioner Conference this year and the past 4 years at the Midwifery Conference, teaching them oral health. And a big project we're working on is with the Nurse Family Partnership. This is a group of home care nurses who are assigned to first-time at-risk mothers. They go into the homes while the mom is pregnant, and they're assigned for 2 years until the baby is 2. So we've been teaching them. We've worked with 6 different states of nurse family partnership now, teaching them oral health so they can teach the moms for themselves and the babies. And we have data from Florida so far, because we're collecting data in Florida and Washington State on the nurses and the moms. And just our 90-day data really shows a significant difference from baseline to 30 and 90 days in the amount of information that the mothers have gotten on oral health, on preventing cavities, and how often they're cleaning the child's teeth. So we're going to follow these children until they graduate at age 2 and hopefully not have any white or brown spots on their teeth at that time. Okay, we're also very proud of our students who've started their own interprofessional group, and we have the founding president, Navjot, here with us today. We're doing a lot of publishing. Our most recent article is the Oral Health in Pregnancy, published in July. We've developed these oral health literacy products to use in primary care with the American College of Physicians. And we have a very active social network, too. We have our website where you can get any of our resources that I've mentioned here. Also links to our blog, our Twitter, our Facebook, our newsletter. So be sure and go to our website and use it. So we feel that oral health is the missing piece in primary care. And if we want our health professions to work together, the students need to learn together, because it's through knowledge that they'll learn to trust, respect each other, and collaborate. Okay.
This gets better by the minute. Thank you, Erin. Our next speaker is Susan Hyde from UCSF School of Dentistry, where she's the chair of oral epidemiology and dental public health. And she will tell us about their experience at UCSF.
Good morning. I'm so pleased to have the opportunity to speak to you today about a new peer-to-peer format for teaching interprofessional oral health education to undergraduate medical students. Just a bit of background for this project. In 2008, the American Academy of Medical Colleges determined that oral health really needs to be part of medical education. And now for step 2 and step 3 of medical accreditation boards, there are oral health questions. In 2011, the Institute of Medicine's Improving Access to Oral Health Care for Vulnerable and Underserved Populations acknowledged that in order to increase oral health care access for underserved populations, we really have to integrate some oral health into primary care. HRSA then followed up with their report in 2014, Integration of Oral Health and Primary Care Practice, where they really set up 5 core competencies that need to be taught to primary care providers who aren't dentists. So despite the fact that for about 8 years now there's been a call for integrating oral health into medical education, at UCSF there was no oral health being taught to the undergraduate medical students. So the specific aim of our study was to describe the development, implementation, and evaluation of a peer-to-peer interprofessional oral health module and clinical skills session that's integrated into the existing physical exam curriculum for all first-year medical students at the University of California, San Francisco. So for the methods, we started off in 2014 with a very simple needs assessment of the second-year medical students as well as the graduating medical students, just asking them, would you like to have oral health as part of your curriculum? Have you learned about oral health during your time here at UCSF? And how comfortable are you in examining and in describing what you see in a patient's mouth? The response was overwhelming that they haven't learned anything about oral health. They would definitely appreciate it being added to the curriculum. So late in 2014, faculty and students from the schools of medicine and dentistry formed a working group, and we really credit the success of this program to the fact that we spent about a year planning and preparing for the integration of this into the existing curriculum. This was not an add-on, this was not an elective, this was not a one-off. This is the exact format and protocol that all the other coursework would be taught for this physical skills session. We based our curriculum on HRSA's 5 core competencies, and much like Dr. Hartnett described, changing the HENT exam into the HENOT exam, and I'm going to go into greater depth about the curriculum in my next slide. We did a pre-oral health module, brief survey and evaluation of the medical students, implemented the module and the hands-on skills session, and then did a follow-up survey to see what changes have occurred. We also evaluated the dental student preceptors and the faculty preceptors to see how they thought the session went as well. So the curricular design, we used a flipped classroom model where the medical students had to watch a 30-minute online lecture, and it covered oral systemic connections, global burden of disease, some basic anatomy, dental caries and caries risk assessment, the mechanism of action for fluoride, periodontal disease, common soft tissue lesions, as well as how to write a descriptive referral to a dentist for your findings. We also had 2 3-minute videos that demonstrated how to perform an oral screening exam as well as a fluoride varnish application. And we had some additional resources that were not mandatory, but they were very informative, such as a guide to common oral pathology, as well as a caries risk assessment form and a list of dentists in the Bay Area that accepted Medicaid. What is really unique in this model is that all of this educational material was designed by senior dental students with faculty input from me, but they were really the drivers of this. And I think, preparing the next generation of educators, I think, is also an onus for us in terms of increasing the legacy that we leave behind. So after the medical students watched things online, they then came to a small group training session that lasted for about an hour. There were 8 medical students to 1 senior dental student preceptor. As faculty, we kind of hang back in the background and provided additional support, but this was really student-led, and that was a very important component of this. The dental student preceptors reviewed how to perform the oral screening exam as well as the fluoride varnish application, and allowed the medical students to ask all sorts of questions that they may have had from looking at the video. Then the medical students paired up and they practiced on each other with a dental student as well as the dental faculty, kind of serving as hands-on feedback and advice. The learning objectives for both the online module as well as for the hands-on face-to-face session were to discuss the relationships between oral health, systemic health, and global health, perform an oral exam that screens for disease, dysfunction, and discomfort, and write a descriptive referral of your findings, assess the risk and protective factors for dental caries, as well as perform a preventive fluoride varnish application. Okay, on to the results. So the pre and post module evaluation was very brief. We wanted to have a high response rate, and we did. We got about 85% response rate. And it was basically asking whether or not the medical students thought that oral health was an important aspect of oral health, how comfortable they were examining a patient's mouth, how comfortable they were in describing what they saw when they examined the mouth, and how comfortable they were in assessing caries risk and performing a fluoride varnish application. The responses were on a Likert type scale, with 1 indicating the lowest level and 5 indicating the highest level of agreement or level of comfort. Additionally, for the post module, we asked 2 questions: whether or not the oral health for medical students module is a valuable part of their medical education, and whether or not the module substantially improved their knowledge of oral health. We compared the responses pre and post to those questions and found significant improvement in attitudes that oral health is important to oral health. Oral health is important to overall health, and that increased comfort in examining the mouth, describing the mouth, assessing caries risk, as well as performing fluoride varnish application. We also gave the medical students a chance for open-ended responses, and their responses were analyzing using standardized qualitative construct analysis. So for example, 16% of the comments related to applicability of this module to future practice. And a representative comment would be, this was a great demonstration of why interprofessional teams are important and how they're applicable to the real world. 28% of comments related to the quality of session, such as great addition to the curriculum and very informative. 13% of the comments related to the construct of peer-to-peer teaching format, which representative comment would be very friendly instructors, great to meet them and learn from them. And 19% of the comments remarked upon appreciation for the session, such as thank you for taking the time to come to us. And finally, 24% of the comments related to suggestions for improvement, such as I wish we had more time to practice. We also evaluated the dental student and the faculty preceptors. The questions asked of the dental students are in red, and of the faculty, there are in blue. Basically, the same 5-point Likert scale, where 1 is the lowest level of agreement and 5 is the highest. And for the dental students, they had strong agreement for it being valuable for dental and medical students to engage in joint interprofessional activities, that they were comfortable teaching the first-year students, that they would recommend that this module is a valuable opportunity for incoming dental students, and overall, they really rated their teaching experience as being excellent. Similarly, the faculty felt very strongly that the fourth-year dental students were very good in providing interactive teaching on how to perform an oral exam and floor varnish, that the dental students were comfortable giving feedback to the medical students, that it was valuable, again, to engage in this interprofessional type of activity. And again, the faculty really rated their experience as excellent as well. So at UCSF, integration of oral health into the undergraduate medical curriculum is desired and valued by the medical students. The oral health curriculum was shown to significantly improve the medical students' positive opinion for the importance of oral health to overall health, increase their comfort examining the mouth, describing the mouth, and performing caries risk assessment and applying fluoride varnish. And also that peer-to-peer teaching format is an effective method for promoting interprofessional education that could be expanded to additional health professions. So for our next steps here in 2016, the School of Medicine has gone a complete curricular revision, totally different now. So students are no longer practicing physical exam skills on one another, and instead, the first-year course is very hypothesis-driven, and we're using standardized patient. So for our session, we are going to be working with ophthalmology as well as otolaryngology and writing up a standardized patient scenario. And we will also be incorporating a standardized interprofessional handoff tool called the ISBAR referral writing format so that students can, again, work together in working up a common case. For the second-year students, we are now adding oral health into an interprofessional geriatric case that is worked out over the course of a 2-day session, and this is going to be in the life cycle course. So these second-year learners are the first-year learners that were exposed to the HENOC curriculum last year, so it's going to be a nice sort of follow-up to that. Faculty and students in the School of Nursing heard about the huge success of the HENOC curriculum, and so they came to us at the School of Dentistry and requested that we do the same for them. So in the fall of this year, we will be expanding our curriculum to the family nurse practitioners as well as the adult geriatric nurse practitioners. Additionally, I've worked with students in the AGNP program to create a geriatric OSCE for the second-year learners that does include oral health as a component. So things are moving forward at UCSF, and thank you very much for giving me this opportunity.
Real progress. Fabulous. Our next speaker is Russell Mayer. Did I get that right, Russell? Close enough, okay? Who's the Director of Family Medicine Residency Program at the Central Washington Family Medicine, and he will speak about integrating interprofessional oral health education into a rural family medicine residency. A different kettle of fish. Please.
Thanks. So good afternoon, all, or morning, depending on what time zone we're in. Sometimes a little discombobulated that way. It's really a pleasure to be here, and Judy, I thank you and the committee for getting such a stellar cast here. I'm a family physician. I practice in a rural and underserved area. I'm still doing fairly full spectrum practice. I work in the hospital, I work in nursing homes, I do home visits. I did have to give up obstetrics a few years ago. My apologies, Renee, but it's tough when I'm not around much to do that. Thought it would be important to give you a little context because it is a different kettle of fish. So I live in an agricultural valley in eastern Washington. We're very different from western Washington. Most of you are going to envision Seattle when you think about Washington. I live in the next poorest county in the state. We have essentially no high tech. Most of the apples you eat, some do come from New York, but most come from my neck of the woods. The population, because of that level of poverty, doesn't attract a lot of high income earners. Therefore, you don't have a lot of professionals. So if you divide Washington into 2 states, we have about just a hair fewer physicians than any state in the country per 100,000 population than Mississippi. So we're pretty underserved. However, we're working to fix that, being a health center in 2 counties in that area and training a number of residents. The program has been there since the mid-'70s, and in the late 90s, early 2000s, our community became involved in oral health as we looked at the need of the community. Fortunately, with the Surgeon General's report in 2000, a novel set of HRSA grants came out that suggested it might be possible to teach physicians about oral health. And we were an early guinea pig working with the University of Washington Pediatric Dental Pediatric Dental School and the Family Medicine Department. What we found as we developed that curriculum is 1, you could teach residents about oral health. 2, they would retain that knowledge. And 3, there were a lot of other people in the office who wanted to know about oral health. And we found that our nursing staff, who was answering the phones, rooming patients, was actually a critical group to educate. So what do we do in our setting? Obviously, we're delivering clinical care as a health center. And so when working with patients, the mainstay of that activity includes the entire staff. We've been talking about interprofessional practice, interprofessional education. We do operationalize that. It is the MAs, it is the RNs, it is the ARNPs, it is PAs, and it is the physicians who all work together on the oral health aspects of our practice. We're applying varnish, we're doing screening assessments. Many families don't have toothbrushes. I couldn't tell you what brand of toothbrush we hand out because I do a good job staying relatively blind on those things. And as any activity, there need to be regular training. So about twice a year, we work with staff, and every 2 years, we go through the entire Smiles for Life curriculum. The educational aspects of our program, fundamental, as I noted, is that Smiles for Life curriculum, and thank you to my colleagues for doing such a good job describing it. We integrate it in multiple places, traditional lecture-type formats. We include it on independent study on various rotations. And in all of these settings, it's actually quite a diverse audience. 2 weeks ago, not at all planned related to this, I was giving the Systemic Oral Health Connections lecture to our group of learners, which included a pharmacist. So when I was talking about salivary issues and dry mouth, the pharmacy student said, "So you mean as a pharmacist, I can talk to my patients about oral health care?" So I think you all are getting a good sense that we are changing the environment out there step by step. As we do this training, as also been noted, we are reframing the physical exam. We're going from HENT to HENOT. For those of you in medicine, I would challenge you, what part of the body would we stop lecturing about? Since we haven't lectured about the oral cavity for so long, maybe we should bring in the oral cavity and stop teaching the pulmonary exam. So it's ridiculous. And it is ridiculous that we haven't been doing the HENOT exam, that this is time for it to enter back into medicine. We are, oddly enough, right across the street from a New York affiliated dental residency. So we bring the pediatric dental residents across the street into our clinic. Many of them have never seen what happens in a medical clinic. They have never seen what is the life of their patients outside of a dental clinic. So they come in, and we are interdisciplinary. We have 2 pediatricians who work in our practice. They come in, they work with the pediatricians. They see what happens with those pediatric patients, what might be involved in those preoperative physical exams and clearance for the oral surgeries that unfortunately so many children still require. But with the work that this group is doing and you all will do, we will stamp out. And we do the converse. We send our family medicine residents across the street into the dental clinic. Fortunately, most of them have had some time in a dental clinic, but essentially always as a patient. And now they get to see on that side how to do a really good dental exam. What happens in a dental clinic? Not all kids need drilling and filling. There are cool other things that can be done to treat early and incipient carious lesions. I wish life were perfect, but it might be a little boring that way, but it's not. So there's some things that have worked well, some things that haven't worked well. So huge successes for us are an impact on the system. So in my neck of the woods, I have watched a community go from no fluoridated water, no physicians talking about oral health, to a community where most physicians talk about oral health. To give you an idea of the difficulty of practicing in a poor and rural area, there are no private practice pediatricians in my county. All of the pediatricians work for health centers, and about half of all of those pediatricians work for our health center, because when that pediatric practice went bankrupt, their only resource was for us to come in and help them. So it's a significant impact, because that gave me a captured audience to teach about oral health and get incorporated into their practice. We use it in our UDS measures, uniform data set measures, that health centers are responsible for doing, to look at QI projects. How many kids are in a dental home? How many kids are getting dental varnish? And I watch and as I read my resident notes over the years to see how these things become incorporated into the note. Barriers, we don't have a lot of measured outcomes. Has all of this work really improved the health of the population? It's hard to know. We have indirect measures looking at the increased rates of fluoride varnish that are occurring in our county and the state of Washington. They're much higher. But we don't know what else is really happening. EMRs, if you've seen an EMR, you've seen an EMR. They're not terribly friendly to changes. And even if they are friendly to changes, you really need to know your IT staff well. But we have incorporated some pieces. We do have fluoride application that is built into the EMR. Imagine that, a medical side using dental codes in their practice. The physical exam templates that are being used do talk about that oral exam. They actually talk about looking at the gingiva, looking at the teeth. And believe it or not everybody just pulls those down and uses them. As I read through notes on patients, I see frequently these have been adapted to what really was there for the exam. So in summary, I think it's been really fascinating to hear the spectrum of talking about professions, the PA professions, talking about nursing and an academic setting, to talk about medical students in an academic setting, and to keep on moving down towards the different parts of the training spectrum and looking at even in a health center. Our health center is not owned in residency. Our residency is not owned by a hospital. It is not owned by a medical school. It's actually owned and operated by the health center. So as we move down, you can do this sort of training in any type of setting. So if any of you walked in thinking, I can't do this because of something about my setting, if I in a health center that is not owned or operated by an academic medical center can do this, you all can do this. It takes a team. It is interprofessional. It is collaborative. It cannot be done on one's own. The materials are available. As you've heard, there's good educational materials. Dr. Hyde describing the relative ease, I think, nowadays of developing your own materials. It does take a champion. You all, as you go back, may not be the champion, but I'm sure you know folks at your site who can be as enthusiastic and excited about doing this as many of us are. We do have next steps that we are thinking. We're scheming about how do we incorporate a hygienist into our clinical practice. Not only do we have significant unmet medical need, we have enormous unmet oral health needs. And with any change, and to keep me grounded being in this area where I was describing, stealing other people's descriptions, these streets as canyons, we need time for reflection. We need time to be able to sit and think about what we've done and where we're going in order to make these changes. For me, living in the West, I enjoy sitting up on my land, looking out and thinking about what to do next. For you, it may be in your office looking over the river, but whatever suits your fancy, take that time, think about what we'll do next, and please help me and these folks here and the other lecturers you'll hear go forth and change the world. Thank you. Thanks, Bruce.
Very much. Our final speaker on this panel is Dr. Mayuma Wilgorot. How did I do?
Pretty good.
Pretty good? Okay. Who's professor at the School of Nursing and Health Studies at the University of Washington in Bothell. And she will tell us about developing and sustaining interprofessional learning and collaborative practice for oral health. Please.
So you have been sitting for a very long time. I see the timer has started, so I'm going to speak pretty quickly. I think the only thing standing between you and your lunch is me, so I will try to, no. Oh, after the Q&A. Okay, great. So, but anyway, I'm on a very tight timeline, and so I will try to go as quickly as possible. I don't know if the slide is going to go up. I want to acknowledge Dr. Joel Berg, the Dean of the School of Dentistry at the University of Washington, who really wanted to be here today but was unable to come. And so I just wanted to acknowledge him. I'm going to talk a little bit about some of the initiatives that we're doing at the University of Washington around oral health and sort of share with you some of our lessons that we've learned along the way. Before I start, though, I want to ground us and put some context into, give you some context that frames our work. This is the Interprofessional Learning Continuum model that was published by the IOM last year, which really attempted to bring the pieces together that we've been talking about and articulate them in a model. And I just want to talk about the top left-hand corner a little bit because that's really where some of our teaching and learning exercises are housed. We talk about different different areas in which people learn. There's the foundational, pre-licensure learning, there's the graduate education, and then there's learning that occurs in the workplace in the form of continual professional development. It ranges from formal to informal kinds of learning, and the point being that we need to, we've recognized that previously most of our interprofessional education initiatives have really focused on the pre-licensure, foundational, formal classroom learning, and we need to start moving this more into clinical practice. That's not to say the foundational is not important, but we need to pay attention to all three different areas of learning. University of Washington, we have a long history of interprofessional education. We've been doing it since about 2006 in a variety of capacities. Some of my colleagues here are here today that can also talk a little bit more about what we've been doing on campus. But I want to talk about iTeeth, which is a program that was created as a result of my Macy Faculty Scholar Grant and my educational project, and it served a number of different needs. The first was that we clearly had a gap in oral health education in our DNP nursing curricula. We also noticed that the pediatric dental residents that when they first went into their residency program didn't have actually a lot of growth and development experience. They had the knowledge around growth and development, but in terms of applying it and having understanding some of the developmental milestones as well as behavior management, how to bring the patient, the child and the family into the conversation were some of areas of need. We wanted to focus on advanced health trainees. Up until that point in 2013, most of our IPE was focused on pre-licensure undergraduate learning. Really wanted to move it into the DNP, advanced health training, pediatric residency, dental residency, residence, and social work curricula. And then we also really wanted to provide interprofessional learning opportunities along the learning continuum. I'm a firm believer in having things grounded in pedagogy. It needs to make sense, and so the idea of creating a curriculum that took the student from the classroom into clinical and out into practice together, I thought would really create a much richer learning experience. And so we created iTeeth. It's 3 phases. I'm happy to go into more detail about it if we have time. But essentially, we started out with an online module with both all students taking a module on interprofessional education, collaborative practice, why we do it. The nurse practitioner students did a module on oral health. The dental residents did a module on growth and development, and then also one on social work. Then the same students come together and spend about 2 hours in a clinical seminar going through 4 cases that we created, 2 of which were based in a dental practice, 2 of which are based in a nurse practitioner clinic, to come up with a plan of care. And then they move on into a 4-hour rotation with the dental residents. So our nurse practitioner students go into the Center for Pediatric Dentistry and spend 4 hours with them seeing patients. My initial hope was that then the residents would then go to where the nurse practitioners practice. It took a couple of years for that to actually happen, but I'm happy to say that this year is the first year that they are doing it. So it really is becoming a two-way thing, because when we talk about interprofessional education, collaborative practice, it can't just be one profession teaching the other. It needs to be a two-way street. Excuse me. I am a pediatric nurse by training, and so I think in pictures, and so I created this visual to try to pull it together and show you where the different components fit. We have phase 1, phase 2, phase 3 that sort of goes along the formal and informal learning continuum, and then the types of learning outcomes that we were hoping to achieve that really went along the Kirkpatrick model. We know from in our IPE work that we can affect reaction, attitudes, perceptions, but what we really need to do is start moving into looking at behavior change. We took a developmental evaluation approach to our program. That basic premise there is that our evaluation evolves as the programs evolve. And so in year 1, we focus primarily on the feasibility of doing this curriculum. as well as whether or not something like this really tapped into those IPEC competencies. Then in year 2, we focused on trying to get a deeper understanding of the clinical experiences, where there were opportunities for collaborative practice and where we might be able to improve upon those. And then in year 3, we focused on sustainability. This work is so important that we need it to be integrated into curricula. We need it to be required as a part of curricula. We cannot be dependent on external funding to keep going. And so it was very important to me to make sure that we structured this in such a way that it was sustainable. And so that's what we focused on this past year. And I will also note that we started very small. We are still very small. We have focused on our PMP students and our pediatric dental residents. And that was partly intentional because we wanted to make sure that we did it right before we started scaling it up. A lot of times people will do a pilot and then we blow it up into this large scale. We wanted to make sure and spend the thoughtful and deliberate time to ensure its success, make sure it was integrated and that students were getting something out of it before we scaled it up. So our first year, we used Boehm's framework to look at the feasibility in terms of whether or not it was acceptable, practical, and whether or not there was any efficacy. And not surprisingly, with our debriefs, we did focus groups with the faculty and the participants as well. The folks found it acceptable, feasible. We used a existing online learning management system. The curriculum was co-created with the dental faculty and the nurse practitioner faculty. And so what that did is ensure that the curriculum was relevant to both professions and really helped with getting some ownership around it. Because, whoops, I'm sorry. Our first year was really, oh no, how do I get back? Oh, there we go, sorry. Our first year was focused on whether or not we tapped into the competencies. Just a thing that I want you to note here is that we did measure on a 5-point scale, but this graph here really starts at the 3, and so it looks like there's this huge jump, but really we started out relatively high, but we did improve their perceptions around the IPEC competencies. We then took the data from the 2014 until now to really look at sort of the overall perceptions and successive phase of the 3 different phases. So we looked at it phase 1, phase 2, and phase 3 overall. And then we went into the skills. We had the nurse practitioner students assess the pediatric dental residents on their ability to incorporate growth and development into their exams, their ability to bring in the families and the parents in their exams, their ability to keep the child in the chair and some of those behavior management kinds of things. And then the dental residents actually assessed evaluated the nurse practitioner students in their skills on doing an oral health exam, applying the fluoride varnish, et cetera. And you can see over time that they did improve. And again, you know, our ends are small, but we intended it to be small. This was a pilot, and so we wanted to make sure that these things really made a difference before we scaled it up. These are our qualitative quotes that we had in year 2, and I'm not going to go through all of them, but basically this will be available in your slide deck. The point that I really wanted to sort of bring up here is that we know the students liked it. They by and large, students always do like some of these activities, but what we found is that they really found the value in having them learn together over time in the same environment, as well as the timing. A lot of times we don't know if the timing is right in the curriculum for this information to stick, and we found that the students really thought that it was perfectly timed in the nurse practitioner curricula so that they could go out and integrate it. This then led to other DNP dental collaborations. We now have some developmental questions, assessment questions that are going to get incorporated into the intake form. Again, this really then
for us is very successful because it really has become a two-way sort of collaboration. Not only are the nurse practitioners being taught, but the dental residents are being not only taught how to do appropriate developmental assessments, but we're actually working together to try to improve the quality of the care that they provide. And so we've whittled it down to 4 questions, depending on the age of the child, asking questions around immunization, social interaction, gross motor skills, and expressive language. Moving forward, we hope to scale up. The nice thing about starting small is that a lot of the other DMP tracks have now got wind of this. Now they're coming to us and saying, can you please do this in our other tracks? And so we don't have to worry too much about convincing other people to incorporate this curriculum. We're tracking our students longitudinally as well as in clinical settings. So we took the sub-competencies, we created 4 behavioral descriptors that are now integrated in all the clinical evaluation forms across the health sciences schools, where the preceptors are evaluating the students' behaviors around collaborative practice. Again, our attempt to kind of move up that Kirkpatrick scale and get at behaviors. And then our next steps with our IT collaboration to really get those questions integrated into the intake forms. I just want to end by making one quick note about sustainability. I think that we cannot think about sustainability without thinking about organizational and culture change. If we want to, we talk about integrating into curricula, but we can't discount the importance of really needing to change the culture of where we work in order to facilitate collaborative practice. And so we were doing a lot of things sort of in the periphery to kind of help move that along, including site development. I think I need to stop, so I will stop there. I just want to end by acknowledging some key people without whom any of this would have been possible, particularly the Macy Foundation for their support. HRSA, we also had some grants that we were able to leverage to help the creation of this. And then all these other entities up here were really instrumental in helping get this program launched. So thank you, and I will stop there.
So, all of our panelists have mics on, so I'll stay here. But we're now going to have some questions. We have about 20, 25 minutes left for questions. Al?
I got it for you.
There's a mic coming, I know.
Thanks.
I think first, congratulations to each of you. What wonderful representatives of what you're doing. It was a real treat to learn with you. It strikes me each of you revealed inadequacies or gaps in the traditional education in each of these fields. Mm-hmm. Is there a mechanism in any of your minds to do a feedback loop to the parent organization from which each of us come, that maybe there is a problem in silos not being aware of the gaps, and that they only seem to be revealed when they're publicly recognized by someone outside of the silo? What do you think?
Well, at UCSF, as part of the curricular change that the School of Medicine underwent, they invited me and a couple of other representatives from the School of Dentistry to participate in, gosh, it's like 3 years of planning. And we had to really basically filibuster to get oral health to have room in the curriculum to make it into the San Francisco 49ers, which meant that another topic had to be kicked off into Alcatraz Island. And we had to make a case of why, again, the burden of disease, the oral systemic connections. And so I think from that sort of even basic 3 years ago planning stage, there was a recognition, there was a development, and then because we actually did take outcome measures, with regards to how the students felt that their comfort level increased. I think that is arguing well that as they're implementing this new curriculum, that they are keeping that place for oral health.
Sure.
Some of us, I'm sure, in the room
Here comes the mic.
some of us in the room are exquisitely focused on a particular area, and some of us, I suffer from being a lumper. So as a lumper, is oral health more relevant when we talk about the load of chronic infection and we introduce the load from vaginal infections and oral infections and GI infections and so forth, and that tooth loss often represents the consequence of a chronic infection load, and I would argue a particular genotype? What do you think?
So I'll take a stab at that. Being a family physician, I step on everybody's turf. So I think it's not, in some ways, unexpected that it was from family medicine came an oral health curriculum that was for all professions, not just medicine. If we look at functional health systems, they all really do depend on a really strong floor. And typically that floor, if we look at the rest of the world, is a really strong primary care base that in many countries is made up interdisciplinary of more than just physicians. And we have a system right now that's really focused on the tip. Per your tipping point, our system is collapsing because it doesn't have a base to support the tip. We need the tip. We need really refined genetics to help us figure out disease. But we need generalists, which are the place where folks first have contact with the system. So as things move in pendulums, we moved from a very generalist education system in dentistry and medicine back in the 1800s, early 1900s, to a very subspecialty focused education system. And we're just part of that natural continuum, I believe, moving back into getting a more generalist education. There's so much knowledge now. Our role as educators is really to give people a good floor. And that part of that floor is oral health. It's just ludicrous that we would leave it out of teaching the physical exam, out of the disease process, which we have done for the last 100 years.
Thank you.
In your system, oh, go ahead.
I wanted to address your first question about the higher-ups are recognizing this. And we've seen the nursing profession to start to integrate it. For example, the nurse midwives now have oral health as one of their competencies. The pediatric nurse practitioners, it's part of their questions on the certification exam. And we've been asked by the National League of Nursing and American Nurses Credentialing to develop curriculums for their websites so that it is becoming a competency for them as well. So it's just taking a little bit longer.
Again, to tag on to that, one of the things that having the luxury of pulling national organization leaders together is it really unearthed for us some of the processes that we use to develop standards for accreditation, questions on certification exams, and that for many professions, not just the PA profession, what we use is a survey of current practice. So how do we change what we do now to prepare for the future? When our standards, our certifying questions, and a lot of the regulatory mechanisms we use are based on what we're currently doing today. And can I comment just real quickly on the second question? And that is, again, with respect to what Dr. Evans said earlier, once that person hits the system, they become a patient de facto. And I think, again, in terms of thinking about silos, one of the things that we haven't paid attention to, again, for a very long time are those social determinants of health and how the environment, as you put it earlier, really fits into this larger picture.
Thank you.
Two observations and then a question. As a new dental school dean in the mid-90s, I went to one or two IPE conferences and walked away incredibly disappointed. And today is so refreshing, and to see the activity over the last couple of years, just absolutely wonderful. The second observation, most of the presentations we've seen are about oral health into other professions. So it was really nice to see the presentation from the University of Washington about dentistry actively being a recipient of interprofessional education. My question has to do with the delightful, quick, offhanded remark you made about pharmacists, and a pharmacist asking. So one of my non-day jobs is I'm chair of the board of Oral Health America. And last year, we actually did an IPE conference in collaboration with Nova Southeastern University on oral health for pharmacists and pharmacy students. And I'm wondering whether there are any pharmacists here, because I haven't heard a lot of that, and I agree with the sentiment of your question. And I ask, pharmacists are one of the first lines that patients run into frequently, more than they do the rest of us. So where is pharmacy in this discussion is my question.
Well, I can tell you in most of the IPE conferences that I went to in the previous years, there were no dentists in the audience, okay? All right? So it's changed. But
I think there may be a response over there to the pharmacy question.
I have a comment, not response.
yeah. Go ahead.
Okay. Well, thank you very much. It's nice to see the progression of developing the curricula. But the interprofessional education is about a process, and I think the field should move into practice. So how we implement it in real life. So I think we should start to talk about interprofessional healthcare. And the healthcare system has an outcome, and both the dentist and the pharmacist and all other healthcare providers working towards that outcome, whether it's related to dental or related to general health. My observation is that in most of the slides you presented, where there is a clinical exam, there is a violation of infection control practices. And I don't know whether we use different standards, but if we follow the CDC standards, examiners need to use gloves and masks, especially when they have their head on top of a child.
Good comment.
So can I just
Yes.
comment on the comment about the pharmacist? One of the things I actually did not bring up, and I'm sorry that I didn't, was that the IT program is not really is not sort of restricted to nurse practitioner and dental residents. We actually had social work students in there, and we also now have pharmacy students for that exact reason. And they are now doing some rotations through the Center for Pediatric Dentistry. But I do think that we can't talk about interprofessional collaboration without talking about organizational change. We really need to work at changing the culture in the way that we not only educate students, but the clinical practice sites that we are sending our students to. And so it's really, really imperative that we do some of that side work as well. Otherwise, it's not going to stick. It's going to be another fad that we're just going to check off.
I would only echo Dr. Ismail's suggestion that we need to move to IPP, that is interprofessional practice.
Right.
And I think some of the things that can do that are within reach right now. I mean, I've talked about a practice of the future, but it should be a teaching service so that medical students, nursing students, dental students all see this happening before them. I was going to ask one question. What do you think the impact, Russell, what do you think the impact would be in your practice, and I don't know how the payment system works, of having someone who was both a dentist and a family practitioner physician in that practice?
Where I practice, so the payment system right now, that is a huge problem, and that's a part of getting oral health in, is fixing our payment process to focus on outcomes, because that will lead to that sort of activity occurring. It would be pretty easy in my setting to have someone who had that breadth of training, and it would probably be more of a hybrid of not a full medical school and residency and a full dental school, but a hybrid of that training to make them, dare I say this in an audience that has a number of dental people in it, more of a mid-level or allied health professional provider who has skills in both realms. That would be incredibly valuable.
Yes.
I'd like to just share real quickly in response to some of the discussion in the last couple of minutes. I described very briefly a model that we used in Manitoba from the University of Manitoba. And we actually do a lot of IPE in undergraduate medicine, nursing, dentistry, et cetera. This charge was outside the university. It was into the practicing community. Because our thoughts were, you know, we have a captive audience here at the university, our students, and we're teaching them this. But how do we go about backfilling the practicing community? And the model we put into place was an all-day oral systemic health program that was actually, we actually captured about 200 physicians that were already part of a continuing medical education program. And we had about 100 dentists, we had about 100 hygienists, 75 nurses. It was a huge, huge program. And it was a very, we used the IPE model, so we were learning from each other. And we did case-based learning. We actually did simulated patients, standardized patient care, that kind of thing. But what came out of that was awesome because it allowed us, the university, to step back and let the professional community go ahead and push for reform in this area. To the extent that they are now, people from outside the university are actually requesting that oral health now be included in the intake exams in the hospitals and in the trauma units and in primary care.
With remuneration?
With remuneration, that is correct. So that was probably the most successful event we've ever had at the university. And they took it to the wall for us. It was really a very successful model. So, and we have tracked those practice outcomes. There have been research papers published out of this, but it was very successful. It did make a huge difference. And it was just, and we also invited students to come into this so that they could learn the reality from practicing professionals, people who are seeing patients, and the barriers to doing this in care, in real life care, is just a really, really rich experience. So,
Did you invite legislators?
Yes, actually we did. We did have a few people from the health minister's office there. Yes.
Thank you. Yes. Oh, sorry. She's picking because she gives the microphone out first before I select someone, so I better pay attention.
Apologies, and pardon any ignorance that might be in my question. I'm an anomaly, I'm assuming. My background is in design and business development, and I'm a historian of science, so dentistry is a new avenue that I'm exploring more just because of a personal, like basically 2 weeks ago I had an emergency extraction on a root canal, and that I had registered for this beforehand, but my question now is even more. I think it's a good point to discuss. So this background will set up my question. So I was diagnosed about 5 years ago with autoimmune disease and thyroid issues, and that was spinning the doctors in circles, and it was spinning the doctors in circles even when I was younger, like a couple years prior. But when I had the tooth extraction, my tooth wasn't hurting. I graduated, I got my master's in May, so I was still in like research mode, and I was doing my own research. And I was like, okay, maybe I'm not about to have a brain aneurysm. I'm like, maybe I should go check out this 10-year-old root canal and ask for an emergency x-ray. So I found someone who would take me right away in not 3 weeks. And it was a definite fairly bad infection that was near my sinuses, and that was why I was having these like headaches. And so I had the tooth extracted, and when they took the tooth out, everyone was like, whoa, and passing around my tooth like it was a three-headed lizard, because there were, basically for 10 years, I've had metal posts exposed beyond my root and against my nerves. And so they were like, yep, that's probably why you had those issues. So my question is based on listening to the different curriculum advancements, which was very encouraging, and seeing how to increase peer-to-peer learning and how to empower and connect the dynamic of the social politics of healthcare itself and the various teams. But what about as the role of like dentistry and even physicians and nurses to empower patients themselves to know to ask some of the questions and the connectors that, oh, tooth issues might be connected to immune response or sinuses, and how do you empower them to know to, in addition to asking questions of background and like family history, telling them, hey, did you know? So is there somewhere in the curriculum stage of having a behavioral, teaching your students to be teachers of their patients themselves so that patients become empowered people to know where to go and ask for their
They're taught it. The question is, in their practice, do they use it? Since they're so intent upon doing the whats rather than the whys. But you can teach us something about design thinking, can you? So what would you do? Whoop!
So basically, I know there's been more talk about bedside manners, but it's been more so in the hospital setting. But as part of the curriculum planning, thinking that all medical professionals are teachers in themselves, and like just because you're a teacher doesn't mean that you're not a student. So not forgetting that dynamic, it is like a two-way aspect. So if there is an incorporation of how do you perceive the role of adult development in transferring communication and having that be part of the study process, as opposed to just like learning about anatomy and learning about various health issues. It's like, how do you communicate with people? How do you learn? So that way,
Communication is a big part of new curriculums. I think everybody can do that. And my own institution, since a mandatory review of systems, oral health review of systems is put into general medical examination and history taking for all the medical students, it's uncovered amazing things. But that's not easy to do with a lot of medical students. Yes?
And the big focus in our curriculum is for the nurses to make the oral systemic connection. And we're not, teaching them to drill and fill. We're teaching them to know the oral systemic connection and to know how to educate patients and educate them in oral health and prevention of problems. So there really is a focus on that.
So I think I'm just going to I don't want to say twist, but basically, I think what you're really talking about, if I'm understanding correctly, is this notion of this patient-centered care and involving the patient and the families in that care, in the delivery of care, and the planning of care, evaluation of care, all across the spectrum. And so my response to you would be that I think as a pediatric person, we're all about being inclusive of the family. We have our patients and our families actually participate in help creating our cases and our curricula. We have, in some of our other IP work, we have patients and families actually on our advisory boards and really helping us ensure that that voice and that perspective is heard.
I want to thank Dr. Donoff and the panelists for a very exciting plenary, and amazingly, we're on time. So lunch is going to be outside when you walk out here. Some people are going to want to go outside too, because there's seating outside, and you need to be back at 12:45. And the doors will be locked at 12:45. Thank you all.